Hello, greetings from the United States, Houston, Texas. Thank you so much for inviting me to be part of this meeting. I'm sorry I can't be there in person, of course, with our new virtual world, but I hope someday to be able to visit. And it's always a pleasure for me to be able to speak about functional outcomes related to transoral robotic surgery. So with that, I will just list my disclosures here. I guess most relevant to this talk is work that I've done on the Scientific Advisory Board for PDS Biotechnology and served as a consultant for Intuitive Surgical. But of course, I'll also disclose that I've never been to Hong Kong and I would love to visit at some point. So hopefully we'll get to meet in the future at meetings down the road. So the title of my talk is Optimizing Functional Outcomes Using TORS. And for the most part, my experience is related to patients with HPV positive disease. But of course, we have a long history of treating oropharynx cancer, HPV positive and negative, using radiation as the backbone. And we know the impact of this treatment. So here's a slide given to me by one of my colleagues, Kate Hutchinson, that shows the baseline function of a patient with oropharynx cancer using modified barium swallow. You can see at 1 year's time that there's some edema, the epiglottis is thickened, some residue in the vallecula, but an overall serviceable swallowing. However, by the time patients get to 7 years, the swallowing is dramatically affected. And this is almost uniform. You can see there's a lot of pooling of secretions. The patient struggles to get consistencies down. And we see this not just on imaging, but hear it from our patients. And of course, there's risk of aspiration and pneumonia. Now, in the US, we've seen a dramatic shift in the proportion of patients who have HPV-related oropharynx cancer. And it's a very unique biology that I'm sure you're aware of, but these images, I think, highlight that well. So this is a patient who came to see me for a mass in his tonsil. You can see typical verrucous appearing lesion at the superior tonsil starting in March of 2013. Now, he continued to photo document his tumor. You can see here in 2014, later that same year. He was excited in 2015 because it seems smaller, but of course this was some tumor involution. And then eventually came to see me in 2015. So it gives you an idea that the time frame of this disease is much, much more favorable than compared to the tobacco-related malignancies that we used to see a lot in the US and that now remains, I think, a predominant pathology in Asia. And so because of this, we know the prognosis is excellent for patients with HPV-associated oropharynx cancer. And so much of the discussion now with my patients is around function. What treatments offer patients the best functional outcomes long-term with an expectation of survival? Of course, at my institution, we don't operate in a vacuum. We do use the single port device as shown here, but there's nothing magical really about the instrument itself or even the procedure. It's really how does surgery fit into the multidisciplinary paradigm? And so the goal of treating surgically is to tailor the treatment based on pathology, same as we would do for most cancers in the head and neck, oral cavity cancer, skin cancer, salivary cancer. All of these are treated surgically, and we decide on adjuvant treatments based on the pathology. For HPV positive disease, if there's no nodes or a single node and the margins are clear, then patients can be treated with single modality alone and avoid radiation. If patients have more than one node, but it's contained within the capsule of the lymph node, or at least there's no macroscopic extranodal extension, then these patients can avoid chemotherapy. And by doing this, we hope that we can de-intensify treatment in a way that optimizes long-term swallowing function. So a lot goes into patient selection. In my practice, again, focusing on HPV positive disease, it's predominantly patients who have stage 1 disease, which is the vast majority of the patients who come into our clinic. Small primary tumors and non-bulky neck disease. Here's an example of a case that would be ideal for TORS. This is a patient that I saw in clinic with a tumor involving the left tonsil here. You can see it's well confined within the tonsillar fossa by AJCC8 staging, HPV positive, stage 1 disease. But what's most important about it is that it's an exophytic tumor. It's really coming out. And this is different than what you see in this image here, this cross-sectional CT image that shows also a tonsil tumor, but there's obliteration of the pterygoid fat pad. It also approximates branches of the external carotid artery here, and it's hard to tell the relationship with the base of tongue. And so I have a lot more reservation about a primary surgical approach in an endophytic tumor like this. I also think a lot about the unilaterality of disease. So patients who have bilateral tumors or tumors involving both sides of the neck are not generally favored for a primary surgical approach. This is an example of a patient with a tumor involving the right base of tongue. There's no involvement of the epiglottis. It does not cross the midline, and it does not involve the larynx whatsoever. And so this would be a favorable candidate for a primary surgical approach. That, as opposed to this patient here, where you can see there's tumor clearly across the midline on the axial CT images that are shown here. While there's not deep invasion, to remove this tumor essentially would require complete removal of the lingual tonsil tissue and some of the tongue musculature on that side. And on the image to the right here, it becomes unclear how deep the tumor is, again, highlighting the risks of a more endophytic type tumor. I mentioned that unilaterality of disease is an important factor. This extends to the lymph nodes as well. This is a patient here on this axial CT with a single ipsilateral node. This would be favorable for a primary surgical approach, at least for an HPV positive cohort. Patients with bilateral neck disease have a higher stage of disease and a higher need for adjuvant therapy. And so generally, I'm not favoring these patients for a primary surgical approach using TORS. I mentioned before about the volume of disease. This factors in as well. Small volume neck disease, small volume primary tumors are favorable. The opposite is true of patients who have large volume disease, as shown in this PET CT image here. Again, it's possible to do surgery in patients like this, but the functional hit of surgery followed by radiation and likely chemoradiation tips the scales in favor of a non-surgical approach in these patients who have a favorable prognosis. Now, as I'll show in some of the slides to come, the calculation may be shifted in patients who have HPV negative disease. So in Hong Kong, it may be a different story, and the rationale for a primary surgical approach may be very different than what we use here in the US. And then finally, there's a lot is made about the role of extranodal extension. You can see this axial CT image here of the cystic node in level 2 has a nice, well-defined margin around it. There doesn't appear to be any involvement of the sternocleidomastoid muscles, and although it abuts the carotid artery, this tumor would easily separate. This would be a very, very favorable tumor for a primary surgical approach. Even if there's microscopic extranodal extension observed, I wouldn't worry about that from an oncologic standpoint in a case like this. Very different than a patient like this, where the edges of the tumor in the neck are very hazy. Clearly, there's some involvement of the muscle. This is a patient, if they were to have surgery, would likely require adjuvant radiation and chemotherapy. Again, so I would not favor this patient for surgery if it was HPV positive disease. Now, if it was HPV negative disease, it could be a different calculation. You might think of intensifying treatment by offering surgery followed by radiation and chemotherapy to improve local regional control. Just a couple words about technique. The images here on the right were provided by me by a friend and colleague, Scott Magnuson, in Florida. This is using the SI device, which we don't currently use, but just highlighting that there is technical aspects that are really important for doing this expertly. And part of that is minimal hand movement to optimize the use of the wristedness of the instruments. Probably even more important is utilizing the high definition imaging. This again is with the SI device, so it is not as good as the current single port device, but the principles are the same. A layer by layer meticulous dissection is required because to take advantage of the imaging, it has to be a dry field. We don't have haptic feedback, and without that, you rely completely on the imaging, the visualization, which can be obscured if there is bleeding. Speaking of bleeding, I have a passion for the safe application of TORS for patients. Myself and others have studied how to do this, and probably the most reliable way to prevent bleeding after TORS, arterial bleeding, life-threatening bleeding, is to prophylactically ligate branches of the external carotid artery at the time of neck dissection. And these are data that we published back in 2018. Others have published it since, and utilizing this approach makes it a safe procedure. Now, I also give patients steroids postoperatively, and this would be for HPV positive disease, HPV negative disease as well. And this is based on a randomized, placebo-controlled, double-blinded trial that we completed and published here in 2017. And these were patients who were given just either an intraoperative dose of steroids or steroids up to 4 days during hospital admission. And what we found in that study is that the patients who were treated with steroids had a quicker return to a more normal diet and were able to leave the hospital sooner. So this is a standard of care in my practice. And in fact, I've expanded it to give patients steroids as an outpatient as well. We do know that the tumor site impacts function as well. So these are data from Emory, looking at patient-reported outcomes as well as digest scores. So observer graded interpretations of modified barium swallow studies. And the bottom line is that baseline status matters, so that swallowing function at baseline is predictive of swallowing function after treatment. That's true of surgery. It's true of non-surgical treatments. Patients who are older in age and patients who have base of tongue primaries tend to have worse outcomes. Just important to remember that and to counsel patients around this. It's also important to recognize, and I think this is intuitive, that patients who are the more treatment patients get, the worse their swallowing outcome can be expected to be. And so this is a study from my former institution using EAT-10 scores, so patient-reported outcomes. At 1 year, you can see the patients treated with surgery alone fared the best. Their swallowing, self-reported swallowing, was excellent, close to baseline, compared to patients treated with adjuvant radiation or chemoradiation, which is decidedly worse. Now, at MD Anderson, we have a prospective registry where we track all oropharynx cancer patients who come through. This is a robust system checking patient-reported outcomes by questionnaires, modified barium swallows. And doing this, we've been able to learn about the differential impacts of surgery and non-surgical treatment in our patients. This is one study that was published here in 2018, where we compared patients who would be eligible for TORS, but were treated either with the primary surgical approach or with radiation. What we found was the incidence of gastroscopy tube placement within 3 months of treatment was about 10-fold higher in the patients who were treated without surgery. You can see 6.1% in the patients treated with TORS versus 44% in the patients treated without. And a more granular look shows even more stark differences. So patients who had surgery alone, none of those patients required a gastrostomy tube within 90 days of treatment. Even the patients who required radiation or chemoradiation after surgery had a significantly less need for a gastrostomy tube at any time. We've also, as I mentioned, looked not just at gastrostomy tubes, but also at self-reported outcomes from patients, the MDADI scores, as well as interpretation of modified barium swallow studies. This is one that was published by my colleague, Dr. Hutchison, where we had over 250 TORS eligible patients. These are patients, again, with HPV positive disease who could have been treated either with surgery or with a non-surgical strategy. And what we found is that based on self-reported swallowing function, patients had better outcomes with the primary surgical approach, and even by objective digest score measuring of barium swallows, there was a signal in favor of surgery, but most strongly, again, for the patients who had surgery alone. We've also looked at quality of life measures using the MD Anderson Symptom Inventory and EQ-5D. What you can see highlighted in blue favors a non-surgical approach, highlighted in red favors a surgical approach. What's important to identify here is that at 6 months' time, whether it's patients who are treated with a single modality or patients treated with a multimodality, favors a surgical approach. We've looked at this in other ways as well. This was recently published by one of my colleagues in radiation oncology, Dave Fuller. This is looking at patients who required multimodality treatment. It's reversed here. So blue is in favor of surgery. Red is in favor of a non-surgical management. And what it highlights is that as the proportion of patients who have external extension or positive margins increases, then the likelihood of an optimal swallowing function decreases. So it favors in red. So as you go further along the x-axis, for example, in this lower panel, with a higher incidence of external extension, it becomes less favorable for a primary surgical approach. But what's most important is that in most scenarios, a primary surgical approach would be favorable, even for patients who have multimodality, require multimodality treatment. Now, I'll shift gears here in the last few minutes to talk about something that I think is very, very compelling. We know from other disease sites that a neoadjuvant approach can be extremely beneficial. We've seen this in cutaneous squamous cell carcinoma, in melanoma, and most recently in colorectal cancer. There is some data, this is out of Hong Kong, where they gave chemotherapy before surgery for patients with bulky oropharyngeal cancer, so T3 or T4 cancers. They do not talk about the HPV status, but presumably it's lower than it is in the US. And I think what's compelling from this study was that they had a 10% complete pathologic response rate. So there was no residual tumor in the surgical specimens, and a 90% partial response. And this has been demonstrated in studies in the US as well. There was a multi-center trial published last year showing similar pathologic responses to neoadjuvant approach with chemotherapy. These days, most folks are very interested in immunotherapy, and we did a trial of this. This study was started in 2016 for patients who had oropharynx cancer treated with primary surgical approach, where the patients would get either single agent durva versus durva and tremi, so CTLA-4 added to PD-L1, followed by transoral robotic surgery. Here's one of the patients who was included in that trial. You can see the tonsil mass here at baseline, and after treatment, there's been some reduction in the size of the tumor. This was, I would say, typical. So immunotherapy, we didn't see dramatic responses for most of the patients treated on the trial, but there was shrinkage of tumor in most of the patients. Here's one example of a patient who had a more robust response. You can see the tonsil tumor here on the left side on axial CT imaging with the associated level 2 node. After 2 doses of immunotherapy, a significant response at the primary as well as at the node. And this actually shifted the patient from needing adjuvant radiation to not needing adjuvant radiation. Here's another example. This is a patient with a left GP sulcus tumor, as well as an associated lymph node in level 2. After treatment with single agent immunotherapy, there was a significant response in the neck. In fact, complete response, pathologic response in the neck nodes. And there was residual disease in the tumor, but it was estimated to be 50% viable. So this is the waterfall plot from that trial, again demonstrating that the majority of patients had some imaging response to treatment, and this was irrespective of HPV status. So we saw it in both HPV positive and HPV negative patients. The response rate overall was about 43%, and because of this, we're excited about CHOW-2, the follow-up trial to this, which is giving patients immunotherapy plus an IL-2 drug prior to surgery, and then dictating adjuvant treatment based on responses. Now, this study will be specific only to patients with HPV positive disease. We know that an upfront approach with chemotherapy before TORS can have a significant impact, but of course it comes with more toxicity. Immunotherapy is not quite as effective as chemotherapy, so we're trying to find the sweet spot where we can optimize the treatment effect with the neoadjuvant approach with limiting toxicity. And we'll see what these data show. Now, in the closing moments, I do want to highlight the opportunity, particularly in Asia and South America and places where the proportion of HPV positive disease is significantly less. This was a compelling trial. This was a retrospective study, but it was looking at the National Cancer Database in the US. So a large number of patients for here, 4,000 patients with small primary tumors were really deciding between surgery and radiation. And what we see is that there's not really a significant difference in patients with HPV positive disease, a slight improvement in outcome for the HPV positive patients treated with surgery, but really a dramatic difference in survival in the patients treated with the primary surgical approach with HPV negative disease, as you can see here. So I think there's a lot to be learned from that. One of my colleagues, Chris Holsinger, designed a trial through the radiation therapy oncology group called 1221. This was specifically to test the intensification of treatment with surgery in HPV negative disease. This study, unfortunately, did not accrue, was closed. but in a retrospective analysis of this group of patients, again, there was a favorable signal for patients who have a primary surgical approach. So very, very compelling disease. And, these are studies that cannot be done in the US. We don't see a high enough proportion of HPV negative disease, but these are the kind of questions that can and should be answered in other parts of the world, including Asia and probably Hong Kong. So in summary, again, thank you for inviting me to be part of this. It's really a privilege to be able to share with you my thoughts around this, and I would love to be there in person to hear from you as well and understand the disease in Hong Kong and how we could potentially even collaborate. I will say patient selection is really, really important, at least if you're thinking about de-intensifying treatment. If the goal is to intensify treatment to improve outcome in HPV negative disease, it would still be important. There are tumor factors that play into my decision-making around HPV positive disease: small tumors, exophytic, unilateral tumors with no or microscopic extranodal extension. But with careful patient selection, I think we can expect really superior oncologic and functional outcomes for these patients. And this is the patient here that took those selfies of his tonsil, and he's doing well, and in fact invited me out for dinner one night. So with that, I will conclude. Again, good luck with the meeting, and I hope to see you in person in the future.